My name's Alex Fanaroff. I'm an assistant professor of medicine at the University of Pennsylvania. So we know that the patients with CLTI have bad outcomes. They have a high likelihood of dying, they have a high likelihood of amputation, and we know that there are large disparities in care with worse outcomes for people from historically marginalized racial and ethnic groups, people of low socioeconomic status, and people from rural areas. And there have been advances in CLTI care, but not as much as maybe we've seen in other areas of cardiology. And we think that one of the reasons for that might just be that there is not the same quality improvement apparatus around CLTI as there is around other serious cardiovascular diseases. So we developed a database of more than 1 million people with CLTI using Medicare claims data, inpatient and outpatient Medicare claims data. And we identified people in that, people with CLTI within that database that underwent outpatient endovascular revascularization. And then we essentially looked at the association between time from CLTI diagnosis to revascularization and the association between that time and clinical outcomes using the standard statistical methods. The key finding is that when we looked at this metric of time from diagnosis to revascularization, which we call diagnosis to limb revascularization time, for individuals with a diagnosis to limb revascularization time of less than 30 days, there was no association between time from diagnosis to revascularization and clinical outcomes, including major amputation. But when we looked at individuals with diagnosis or revascularization time greater than 30 days, for each additional 10-day increase in diagnosis to limb revascularization time, there was a 2.5% greater risk of major amputation. And for each 30 days beyond 30 days, there was an additional 7.5% increased risk of major lower extremity amputation. I think that they highlight the importance of early revascularization and moving quickly in patients with CLTI. And not sort of letting them sort of fester with wounds or ischemia or gangrene. I also think that ultimately what I would like to see is for some sort of message about the timing of revascularization in CLTI be built into guidelines. Now, I'll say that I don't think that this research is sort of adequate to change guidelines. I don't think that we're there yet, but I think that what this paper does is it increases the concept of diagnosis to limb revascularization time, and I am hopeful that there will be more research that builds on this, sort of like there was all the research building on door-to-balloon time in the 90s and 2000s that sort of developed the concept of door-to-balloon time and developed the quality improvement apparatus around STEMI, and which really improved quality of care. So I think that the message here is that moving with appropriate speed matters after a diagnosis of CLTI. I think that's the clinical message, and the sort of broader message is that it's really time to think hard about how we're taking care of our patients with CLTI, what we can do to make care better, and whether we can sort of build a quality apparatus around it that's going to help us take care of all of our patients and improve their outcomes. This sort of introduces the concept. I think that the next steps are really to look at, on a hospital or health system level, is there an association between how well a hospital does on this diagnosis of revascularization time and clinical outcomes of patients that are seen in those hospitals. I think that we have to understand what are the reasons for delay. Why is it taking, in some cases, up to 180 days between a diagnosis of CLTI and revascularization? What are the barriers at the health system level? What are the barriers at the physician level? What are the barriers at the patient level? And then the next question is to say, are there health systems that do a good job of this? Are there health systems with low diagnosis to limb times? What are those health systems like? What are they doing that make them successful? A lot of this research will parallel, I think, some of the really important and foundational research that was done with door to balloon time. And I think that's the key to sort of building this out as a quality measure that we can use to give health systems tools to improve care of patients and also give them targets. Yeah, I think broadly that CLTIs, PAD in general, are such important disease states that have such important impacts on patients' quality of life. And it's been really, I think it's been heartening to see some of the really great work that's being done in this space. And I think that we need more. And the patients that have CLTI, the patients that have PAD, should not be forgotten. And we sort of owe it to them to continue to further the science. And it's been good to see that there are a lot of really smart people and great people out there doing it.